So this patient's coming in for removal of a mobile lesion on the left side of his scalp, sort of around the temple area. I'm working with the Dr. Jane again today. I was going to have her do this procedure, but this one is a little bit wider. So it looks like it's maybe a bit of a calcified cyst, or we call it sometimes a galleocyst, or you can have galeolipomas too. And the question becomes, which one of those are we dealing with? So we delineated the margins of it. The other thing I always tell patients to be, or the residents to be aware of, is the reason I've marked these lines, you want to certainly make it sure it's symmetrical. So with your Langer's lines cutting in that plane, when you're dealing with over the ear, you want to make sure that those lines line up so it's not like a curved line or a downward angle. So you want to make sure you look at that, so that you can lose that sometimes if you just do it freehand. So this makes sure this line, I know, will be consistent with that when you look at the overall symmetry of his head. He's nicely shaved this down for us, which is really appreciated. I like your hairstyle, it's perfect for us. And we've checked, he doesn't feel this, so this is all frozen. So this is our number 15 blade here. Just have that for me. So like for most sister procedures that we do, but especially scalp ones, it's all about finding the right plane. So making sure this starts, as soon as we get below the dermis and it starts to open up, then we'll know that we can dissect this down more. And again, like any other spot we look at, what's critical, bleeding planes are critical. So the scalp is a big blood supply, so we want to make sure we're not putting him in a position where once we start, it starts to bleed down either into his face or onto his chest or those type of things. Seems like a minor issue, but you want to make sure you consider it so that you have good procedural flow and you don't find you're panicking when all of a sudden something is extending into a spot that we don't want it to be. So bleeding isn't a big issue, and this is a big part for the residents to get familiar with. So Dr. Jane will start to do more of this. We'll start to get more comfortable with this, because what happens early on is you start to panic if it's bleeding more. This, I would tell you, is very minor bleeding. So even though it's a little bit more brisk than some of the stuff we'll see, it's not worrisome whatsoever. But you want to be familiar with what you're doing so that if it is bleeding briskly, you don't panic and compromise the procedure. So here I just use the Cryleys to protect the underlying tissue a little bit while I extend this. It's not hurting at all?
No.
What do you think? Does it look like cyst membrane? Looks like it. Yeah, I think so. So sometimes you can have a very thin membrane just sitting on top of it still that we have to get through, and I think that's the case here. It's hard to see because how much you bring up is on top of it. You can see that that's the cyst capsule there. I'm trying to show you that there. You can kind of see it there. You see that? Hard to show. See a little bit of membrane there? Yeah. There's just thin adhesions on top of it, which is why it's not quite opening up as much. But once I get below that, stab that just a bit. Just watch your fingers there. Good. So now essentially all we want to be doing is dissecting this down on both sides. Try to open this up and see if we can get that out. So now I can easily see it, so that's the cyst membrane that's there. So this looks completely normal and benign, so just like we thought, this is more cystic than anything else. So what would you see here that would make you worried about that? So let's say we were doing this, we were telling him that it was just a cyst, nothing to worry about, and now we saw something that made us worry that this was actually precancerous or cancerous. What type of things would you look for?
Like tissue that's not
tissue that's not like cauterizing properly, or
Yeah, so that's one thing, but you'll get familiar with what normal tissue is.
Mm-hmm.
So my point being is, you know, and I know you've done enough of these that you're looking at this and saying this is normal tissue. And that's sometimes difficult to sort of explain back to the patient. But if this was like really vascular, like if it was purplish, reddish, black, these type of things, then I'd be a little bit more. And sometimes you can get that from oxidizing, but a lot of times it indicates there's a larger blood supply there, so you may be more nervous with things. Also, in terms of adhesions, how much it's stuck down in and of itself can sometimes give you some trouble.
So the more adhesions,
Not necessarily, but I'm saying sometimes when you're trying to dissect it down and realizing it's more problematic than you thought, it might be tethered in such a fashion you're like, wait a minute, what's going on with this? This has none of that, so this is all I'm doing here is just trying to dissect it down enough. This may have some adhesions underneath it, which I'm running into now, but not from a problematic perspective. I'm just going to stand up a bit.
Where would the vascularity be? Where would you see it? Like on the actual capsule or around it?
Yeah, so see how this is nice and pearlescent? So that's nice normal tissue, sort of a yellowish cream color. You'll see that the cysts will start to look, they'll look purplish, or they'll look very, very reddish. So this is dissected down. You can see how it's popping out as I'm sort of pushing that there. So if I start to rotate this just a little bit, I'm going to do it from the back end as well. And see that just came off of it? See that membrane that's right there?
Yeah.
That's what was holding it in place. Let's come out. Pop it down there. So this is certainly just consistent with a pilar cyst, which is what we had thought would be most likely. So when we incise into this, we should just see keratin that's coming out, which would be that clear sort of material, which is just what that is. And that just confirms with it our diagnosis, right? So now we know the capsule's entirely out, so we'll send that off for pathology. Scoop that out for me. And that's where, just in progressing slowly, we now know that the entire thing is out, and we have no concerns about recurrence or anything of that nature. And that's why generally I'll always prefer to take them out intact. Again, I've mentioned this a whole bunch of times. I completely respect my colleagues and how some of them like to rupture the membrane, and they can do fantastic work with it, but I always am nervous about how confident we are that this has been fully removed if you start to break the capsule down, especially if it's friable. So just going to grab some suture material so I'm in your view. I'll give it to you. So this is our 4-O-Proline. Just add that for me. And you're comfortable?
Mm-hmm.
Just add it for me. So why don't we bother, this is still oozing a little bit, why don't we try and cauterize those bleeds?
You know the sutures will capture it at some point?
Yeah, so and what's that process called? Where it puts pressure on them, what's the medical term for that?
That is...
Remember, I kind of think it's tamponading. So this is why when you see this happening, certainly if you're dealing with other areas, you want to make sure that deep bleeds, that you're actually cauterizing them or tying them off. But with the scalp, you're going to be encircling those with these stitches. And I've, knock on wood, I've never had a hematoma in a scalp lesion, like ever, as long as you put your stitches in properly and seal that off. Just put pressure on that for me. Now sometimes if you have really active bleeds, see what's happening here, these needle drivers, this set here, it's becoming a bit dull. So this set's on its way out. So that's slipping a little bit, sorry. See how that doesn't grab there? The teeth are becoming a bit worn. So sometimes this one's not bad at all, but if it was really actively bleeding and we were worried about, you know, how much pressure was there, we'd put a pressure dressing on this, so almost like a turban that he would wear, just for the first couple hours, just to make sure that that settled back down for him. Just have that for me. Almost done. Right there. So that looks nice and clean. We'll just clean that up and put a dressing on him and he should be fine.